All right, I think we're a couple of minutes over, so we can probably start. Good morning, everyone. Thank you for joining us today in the Grand Rounds. We have our special guest, Dr. Gogia, who's a stroke neurologist. She is, kindly agreed to do a very comprehensive review of Tenecteplase for acute stroke care. I wanted to have a discussion on this topic since we'll be planning to switch over from Altoplace hopefully next month or early November. So I think it just gives us a quick review of why we're planning to make the change, and if anybody has questions at the end, then happy to discuss that as well. Dr. Gogia completed her neurology residency from University of Texas, medical branch in Galveston. And she happened to be my co-fellow in Beth Israel in Boston, where she was pushing me all the time to do bigger and better things. Uh, Currently, she's an assistant professor with the Mercer School of Medicine and also a neurohospitalist at the Piedmont Columbus Regional in Georgia. Good morning, Dr. Gogia, and thank you for doing this.
Thank you, Dr. Hassan, for the kind introduction. I never had to push you, by the way, but sure. It's my pleasure to present on this topic, which has been one of the most trending topics in the past couple of years, and I'm excited to present this. So, really, I have no financial disclosures whatsoever, no conflict of interest. This is the CME code for this session. Number is 1284085. So I'm going to start with the very basics, just at the molecular level. What is tenecteplase? So a very simplified version of this flowchart. As you can see, the tissue plasminogen activator, most commonly we all know by TPA or alteplase. It helps in the activation of plasminogen to plasmin, which in turn degrades the fibrin into fibrin degradation products. So everything in body has to be balanced. So this particular action is inhibited by PAI, which is plasminogen activator inhibitor, which is seen on the red here. So now we're talking, so tenecteplase is a genetically modified version of TPA. As the benefits are, it has greater fibrin specificity and a longer half-life. And the reason being the next slide. So the above molecule is the alteplase, the below is tenecteplase, and they are genetically modified at 3 different locations, which makes it about 15 times higher fibrin specificity and 80 times reduced binding affinity to the physiological plasminogen activator inhibitor. And in turn, it ends up having a much prolonged plasma life, which is roughly about 20 minutes, 22 minutes compared to 3.5 minutes for alteplase. So because of these reasons, tenecteplase can be administered as a single IV bolus, up to 50 milligram, although the recommended maximum dose is 25 milligram, over 5 to 10 seconds. In contrast to, an hour-long accelerated infusion for alteplase, where you have to sit and monitor the patient. So, as I mentioned, when we compare TPA to tenecteplase, TNK, the abbreviated form, has higher fibrin specificity, more thrombolytic potency, higher resistance to the inhibition, therefore lesser clearance and increased plasma life. So the mean initial volume of distribution that was studied in my paper was 4.2 to 6.3 liters, and at steady state was 6.1 to 9.9 liters. Now this means that the extravascular distribution or binding of TNK is limited, thereby decreasing the extra cerebral or bleeding events, and in more rapid restoration of vessel patency to be attained. So why are we talking about tenecteplase when we already had alteplase? Why all of a sudden? Well, it's not all of a sudden. The work has been dated back to 2012, and even before that, TNK was more commonly used in the field of cardiovascular medicine for acute MI and all that. So the first actually positive trial was done in 2012, which was TNK versus antiplace or tenecteplase versus antiplace in acute ischemic stroke. 2012 first positive trial. I'm going to be talking about each of these very briefly in my following slides. But as you can see, the timeline started back then followed by the initiation of the landmark trials, which we're going to be discussing again, taste and test and no test whatsoever. So what happened? Why we did not talk about TNK in the past and why we're talking now? Because of various reasons. So around 2017, 2018, I think that was a time for the diffuse V and the Dawn trial when mechanical thrombectomy trials were taking over any other thing. So in the field of stroke medicine, everybody was talking about the extended window for mechanical thrombectomy. So I think it was overshadowed by that. And then in around 2020, the pandemic delayed everything, the recruitment and the progress of the trial. Finally, in 2022, I first did a presentation during my fellowship, and 2023, it actually became one of the strong recommendations in European Stroke Organization conference after the presentation of the three landmark trials at that point. And 2024 is considered as a year of Tenecteplase, as most places have already transitioned to Tenecteplase. We're talking about the very first positive trial. This is a phase 2B trial, and they recruited about 75 patients. Window was about 6 hours from symptom onset, and at that point, also Tenecteplase was associated with significantly better reperfusion and clinical outcomes compared to Alteplase. This study was based on CT perfusion. They were basing off how much penumbra is remaining and all that. Next is 2015, again, phase 2 trial, again based on CT perfusion. All these phase 2 trials is basically to establish efficacy and safety of tenecteplase, and this was also to show the same. However, it could not show any superiority. It only showed that tenecteplase was equally effective, and the results were not any different between tenecteplase and antiplase. Then coming to 2018, this Extend IA TNK trial. Now, in this particular trial, they gave TNK prior to doing thrombectomy. So, I mean, I think we talk more about the thrombectomy based on this trial than TNK itself. It had about 101 patients. The dose used was appropriate, and they noticed a better functional outcome at 90 days. And now, this was a meta-analysis that was done comparing 8 studies, and they found no differences in terms of good or excellent functional outcome. And TNK rather showed higher rates of recanalization and early neurological improvement, and ICH was reported to be similar in both the groups. Now, this is about the same meta-analysis. Different studies. Out of the 8, 6 were randomized controlled trial, 2 were observational studies, timeline about 4.5 to 6 hours. And the dosage used was approximately the same, 0.25. A couple of studies used a higher dose of 0.4. And again, it showed like TNK was effective with no increased ICH incidence. Now, the most common question is what is the most common used dose of tenecteplase? Because there are a couple of studies that use different doses, and because of that, the results were like kind of iffy, like whether or not tenecteplase can efficiently and safely take over alteplase or not. So 0.2 to 0.25 milligram per kilogram is considered as a dose superior to alteplase for early neurological improvement. However, when this dose is particularly compared to see the better functional outcome at 3 months, it was not statistically significant compared to alteplase, but it was probably the same. So why are we switching? I mean, other than better recanalization, other than better results, maybe one of the other reason is overall cost. So I have an Australian study here. I don't think there's an American study here yet, but this data is US data, and it says TNK, the cost of TNK per 50 milligram vial and Altiplase per 100 milligram vial differ by $3,000. So Tenecteplase is about $3,000 cheaper per case, and we can see that it will overall be a little bit more cost effective. So this is this was a study I mentioned. This is mainly an Australian-based data, and we can see the cost of thrombolysis for TNK was much less than Altiplase, and it was statistically significant also. Now again, I'm mentioning the CME code for this session, if anybody wants to make a note of it. Now, coming to phase 3 clinical trials, the landmark trials that changed the paradigm and kind of brought Tenecteplase to what we have standard of care, if not in all the hospitals, at least in majority of the hospitals already. So the first is the ACT trial. The ACT trial was done in Canada, and then this is a Canadian study and presented first at European Stroke Conference in 2022. It was a non-inferiority trial. Again, the dose was 0.25 milligram per kilogram, and it was a multi-center prospective randomized trial, and one-to-one randomization was done. The primary outcome in all of these studies would be to see 90-day MRS 0 to 1, and the secondary would be 0 to 2 versus ICH versus mortality versus any other bleeding areas or orolingual angioedema. All of these studies would have more or less the same primary and secondary outcomes at 90 days. So the baseline characteristics of the patients they included were pretty much the same. Age, the gender distribution, the NAS stroke scale, they had moderate stroke, like about 10 or 9. And they also had a bunch of severe stroke cases also with NAS stroke scale more than 15. LVOs were about the same also, and the occlusion side, as we all know, is mostly anterior, circulation, ICA and M1 compared to the distal or the posterior circulation. And so as you can see in this graph, compared to Altiplase, Tenecteplase, if not superior, it has more or less the same, functional outcome. So the non-inferiority threshold was met easily in this trial. And the secondary endpoint, they did not see any difference in terms of any ICH or length of stay or any other side effects or adverse effects at that point. So this graph basically, the more black dots you see towards the right, the more in favor of Tenecteplase. This is a subgroup analysis basically. So most of these blocks are towards the right, which means they favor Tenecteplase, even in patients, maybe not significantly enough, but even in patients older than 80, even in severe strokes with NIH, they're closer to right side, midline, but a little bit more on the right side, if we can see. So overall, a little bit more preference towards Tenecteplase. Now coming to 90-day MRS. So again, the same thing in the LVO was achieved much more in Tenecteplase group, and this we already talked about because of better mechanism of action and all that. Like in conclusion, this trial basically reported that Tenecteplase was non-inferior to Altiplase for function outcome 90 days after stroke with similar safety. So therefore, Tenecteplase is a reasonable alternative to Altiplase in patient meeting the standard indication for intravenous thrombolysis. Now, coming to the second landmark, not so much landmark because this was not a positive trial, and the reason I'm gonna tell you just in a couple of minutes. So NORTEST 2A, this trial was preceded by NORTEST itself, which was a phase 2 trial, phase 2, just to show the efficacy. Now, the dose they used was a little bit different in this trial. The dose they used was 0.4 milligram per kilogram. In this NORTEST, they were not able to show any superiority, but they showed similar safety profile, and that's the whole point of phase 2, to show efficacy and safety. So when they moved to do the phase, the NORTES-2 trial, they noted that with tenecteplase, the results of the basically functional outcome was more or less similar. However, again, the primary and the secondary endpoints that they were looking at were pretty much similar to the last trial I talked about. And here they noted the incidence of hemorrhage far exceeded the LTPs. And the reason I mentioned is the dose of tenecteplase they used was much higher. So it's not like any other trial that has proven tenecteplase to be safer compared to LTPlase. So I think the dose made a whole lot of difference. And so they did not, they could not show that tenecteplase is non-inferior. They rather was they reported worse safety and functional outcome. And then they plan to do the NORTES-2B study using 0.25 milligram per kilogram dose. And I think that's been going on. It's a Norwegian study, so it was done in Norway and probably it's been done right now. Now, the third landmark trial that changed the paradigm is TASTE-A trial. Now, this is an Australian study, again presented at European Stroke Conference. This was based on mobile stroke unit as well. So again, similar criteria and everything. The distribution was about the same. One difference compared to the other two studies I mentioned was the use CT perfusion. And volume of perfusion was actually based on the CTP, and the time of onset was so the reduction. So the primary outcome was to measure the volume of perfusion lesion on CT perfusion, and the secondary outcome was reduction in NA stroke scale, pre-treatment and post-treatment. Sorry. And then other aspect like MRS at 90 days and mortality and any ICH. So the primary outcome of the CT perfusion lesion was significantly smaller in patients treated with tenecteplase. As you can see over here, for tenecteplase, it's far more, and for over here, the volume is far less. The secondary outcomes, there was a reduction, significant reduction in NA stroke scale, and meets a significant value as also. And the time to treatment was also significantly different, but I don't see why would that be very different. Anyway, so for the TNK, the secondary outcome, which is the MRS at 90 days, was about more or less similar, if not any more. And then, so they concluded that in the first pre-hospital meaning before they even got to the ED, because this was done in MSU, mobile stroke unit, the TNK was substantially resulted in smaller post-treatment perfusion lesion, greater ultra early clinical recovery, faster initiation of treatment compared to patients treated with IV. One of the reasons I can think of is because it's a bolus and not an infusion, so things can be really moved faster. One reason. And no safety concerns as such, no differences in the incidence of symptomatic ICH, and no difference in mortality as well. Now, the reason I'm just particularly mentioning this could be a trigger for wider use of perfusion imaging for patients with mild stroke within 4.5 hours, where we sometimes, have a difference in opinion regarding thrombectomy because of the milder symptoms. So maybe this could result in more use of CTPs, and large penumbra lesions rather than mild neurological deficits might be identified relatively often. So now talking about the TRACE-2 trial, this is a Chinese trial and phase 3. Now, this was again a non-inferiority trial, and it was able to show non-inferiority of tenecteplase to alteplase in patients eligible. Now, so at this point, we know that tenecteplase is effective, it is safe, and has proven to be non-inferior to alteplase. The next step is to compare tenecteplase to standard medical treatment, like for non-disabling or lower NA stroke scale strokes. We have that data for alteplase in terms of PRISM trial, where we know that TNK might not offer any more benefit compared to dual antiplatelet therapy or single antiplatelet therapy in smaller strokes. So now we need to establish that, and we now need to have a superiority trial. So talking about Tempo 2 trial, which was just published this year in May, not too long ago. This is a Tenecteplase versus standard of care for minor ischemic stroke with proven occlusion, like distal occlusion. A person presenting has a proven ICO or M1 occlusion, and then the study was compared with the lower NA stroke scale, and the study was compared to compare TNK versus antiplatelet regimen. So again, over here, the control, the primary outcome is the responder, meaning, how much they improved and the functional outcome. Secondary outcome is the 1 to 2 MRS in 90 days, 0 to 2 at 90 days, and almost similar mortality and ICH and all that. And so this is the first phase 3 study to examine efficacy of thrombolysis with tenecteplase in minor ischemic stroke with proven intracranial occlusion within 12 hours of onset. Now, why is that important? Because 12 hours is anyway not very typical to give thrombolytic therapy. However, we are basing this off, other trials that we have for alteplase. So higher chances of recanalization was seen with tenecteplase when compared to alteplase. We know that. So the comparison was not with alteplase here. However, if you think about the tenecteplase and antiplatelet, the chances of recanalization, yes, would be higher in tenecteplase. But when they translated this to see if there was any improved functional outcome at 90 days, then they could not see any difference between the DAPT or TNK. Rather, there was potentially more harm in terms of symptomatic ICH, which was about 3% higher. And this result was pretty similar to what they saw when they compared alteplase to antiplatelets as well in PRISM study. So the overall mortality was low, but if we had to compare, then slightly higher in thrombolytic, but not significantly enough. Now, talking about this timeless, now this is also a 2024 study, and this is tenecteplase for stroke at 4.5 to 24 hours with perfusion imaging selection. Included patients with disabling stroke between 4.5 to 24 hours with symptom onset and potentially large penumbra defined on CT perfusion. Now, the TNK was initiated 4.5 to 24 hours with the known occlusion of like MCA or ICA, and most of these patients would undergo thrombectomy. Overall, they did not see any better outcomes when they gave TNK or they just did placebo. Mortality at 90 days were also similar in the two groups, 19.7 versus 18.2, and the incidence of symptomatic ICH was also similar. So the secondary outcome was to see recanalization rate, and it occurred more in tenecteplase compared to like 76% in tenecteplase group compared to 63.9% in placebo. And this was statistically significant also. So what is next? Now we have established this. Now I think they have found another genetically modified variant, which is retiplase, and this study has just started. I think they are recruiting currently, and it's going to be labeled as RACE study. So this was all. Thank you for listening. And again, the CME code for this session. Any questions, I'm happy to answer.
Thank you, Dr. Gogia, for the comprehensive review. Just a couple of questions or probably comment. It's not, tenecteplase is still not FDA approved, right? So, are we, and you may not know this, but are we expecting the cost to go up once the FDA's, approval comes in? And a second question, yeah. Second
Go ahead,
question.
go ahead.
Yeah, second question was, With TPA, for example, there are some relative contraindications for patients more than 80. If somebody has had a previous stroke or is diabetic, according to the ECAS. Uh, are is it all similar now with tenecteplase as well? And are we using more caution with these patients who are older, or I'm not sure what the age groups with these trials was exactly.
So, I mean, about the first question, I think FDA approval might change the cost. I'm not sure because with the altiplase also they have seen the cost is increasing. So that might happen similarly with this. However, it's a competitive market. I don't know how it will happen at that level. But hopefully it won't, it'll still be like a little bit cheaper option compared to altiplase. But again, I don't have the answer to that. I think, if I'm not wrong, even though this is not like FDA approved, but it's on the verge, so it'll be soon. And the second question regarding the age, the more or less all these trials have the same eligibility criteria as they have for altiplase. There was no difference in comparing. So every trial had this line that whosoever was eligible for altiplase like the same patients they actually included in the Tenecteplase trials too. So they particularly did not look, if you remember, I showed you a slide where they did the meta-analysis of the 8 studies. So in that particular study, they did the subgroup analysis and they noted like, I think 2 subgroups were less than 80 and above 80. I don't think they saw any difference when they saw for more than 80 because probably because of the recruitment, right? They are aiming the same population. I don't think there was like in any of these studies they included anybody which is like which were like a patient who would be otherwise contraindicated to have altiplase. I mean, I don't think that's the goal. The goal is to have the same population.
Yeah. Cool, thanks. And
Mm.
what has your experience been? I know, in Boston we were still using alteplase.
Mhm.
And where you're practicing now, I'm assuming is tenecteplase, or have they switched over
Yeah,
yet? Have
yeah,
you
yeah.
guys run
It's
into
been
any challenges or anything that we should know
actually
about?
most of the people are very happy about it. Like because of how quickly it can be given. I personally talked with the, the nursing staff, like how are things over there? Like how are things different? So they are happy because they don't have to sit with the patient for the whole hour monitoring, like while the altiplase is going on. It's a bolus, and so, whatever I have seen so far, I have not seen any increase ICH, and they do fairly the same, maybe a little bit better, I would say, but I don't have a data to show it to you right now because we haven't compared, the 2 sets yet. But if I have to say a recanalization rate, I mean, there is like a different way of how things are done here. So I don't get a report whether they found the clot or not. So
Mhm.
I'm assuming it's better, like they are able to remove the clot easily. But I think that's a good question. I'm gonna ask them if there's a big difference during their procedure. But as far as the asymptomatic ICH or other complications, no, I don't think we have come across any.
Excellent.
Any other questions?
Sure. That was a great presentation. This is Nasser Fakhri, one of the stroke and interventionalists. I just had one quick question for with you guys using Tenecteplase. Anecdotally, do you think it's helping with the door to needle time at all? Because with TPA, the nursing has to set up kind of the drip. I mean, we still
Yeah,
give the bolus, but it just seems sometimes it's more cumbersome, and
yeah,
just human nature being, that it's a little harder for them to get everything together. And my
yeah,
understanding is Tenecteplase, you just have to give the bolus like any other medicine. So
yeah.
I don't know if any studies have shown. Maybe you get a little bit of time shaved off on your door.
Yeah, I
Curious if
think
this
that
is your.
that taste study did mention about that. I'll bring it back. So I think that's correct because of how easy it is to give. So I feel like the door to needle time was actually reported to be less. But
Yeah,
I
with
don't
the
know if
center
we can,
things.
yeah, yeah, I don't know if we can translate to every center here. because the differences, but again, I think they mentioned it. Let me find that here.
Yeah, where I was before, sometimes if they want to get you have to get MRI
Yeah.
compatible drips, and it created some delays, which is nice with Tenecteplase.
Yeah, I think it was here. Yeah, so to ED arrival, I mean, there was a little bit difference, you see. I mean, here, imaging to treatment. So, yeah, I felt like even they mentioned in the results too. I don't have that slide with me. And honestly, most of these presentations, I had to listen to the conference because the papers are, still they were not out yet, and they are Lancet, so I don't have access to a couple of papers also to present it here. But yeah, I think they mentioned it that door to needle time was lesser for TNK compared to Altiplase.
That's great. Yeah, thank you for the presentation.
Yeah. Anybody else? Any preference? I think we have a chart. Any preference from neurointerventionalists of TNK with MT with no, we don't have Altiplase actually. We have completely transitioned, so it's not an option anymore. I think they're just going with TNK. So yeah. And I think it's similar in other facilities too. And this one of the reasons I was asking them is to avoid any confusion in decision making, whether to choose Altiplase or Tenecteplase. So the question was actually any preference from neurointerventionalists of TNK with MT versus TPA with MT at your facility? And the answer is like we don't have two options available. We only have TNK. We completely transition. So I guess if TNK becomes shortage or something, we would have Altiplase at the back, but not readily available. Like choose one or the other. Anything else?
I think that's it. Thank you so
Okay.
much, Dr. Gogia,
Okay.
for reviewing this with us. It's really helpful.
Thank you so much for listening and giving me this opportunity to present. Tenecteplase is nice. Hopefully, you guys transition and experience the same. So
Hopefully.
yeah.
Okay. Thank you.
All right.
Take care.
Bye bye.
Bye-bye.